by the Entamoeba histolytica that may makes it able to penetrate, attach to the epithelial lining, and then penetrate to the underlying tissues and even migrate because of this virulence factors. And those virulence factors also promotes the resistance of the amoeba, the Entamoeba histolytica to the immune system. That's why it becomes or it makes that virulence factors, those virulence factors makes the organism or the parasite pathogenic to humans. And if you recall again, um, amoeba or histolytica appears to be the only parasite that occurs in humans. So transmission is most of the time human to human transmission. So if someone gets amoebiasis caused by Entamoeba histolytica, you expect that the food that was taken by the patient was contaminated with the cysts from the Entamoeba histolytica, and that contaminated food was contaminated by the feces of humans. So not animals but humans, because according to survey, this parasite occurs through human to human transmission. There is no It does not cause zoonotic diseases unlike other protozoans. Okay, so to continue, we'll tackle about today we'll tackle on commensal amoeba. When we say commensal, it does not necessarily cause disease, no? Commensals, they can thrive within your body, they can survive within your body without causing disease. So commensals, they are inert in nature. They're still parasitic in nature, even though there are commensals, because they compete with food. So they parasitize humans, they parasitize mammals because they compete with nutrients taken up by humans or by the victim. So for today, we'll be talking about commensals. However, generally in the clinical setting, patients having commensal amoeba in their intestines are not detected because they don't usually present with signs and symptoms that they have amoeba. So remember, most of the time, commensal amoeba does not give you disease. That's why they're not considered pathogenic. So patients would not manifest signs and symptoms that they have amoebiasis. So when the physician or the medical technologist discovers that you have an amoeba in your stool exam, it is most of the time accidental. No accidental discovery that you have a parasite in your intestine. Now, as a clinician, we have to consider the value of giving medicine, no? Because not all, because these parasites do not cause infection or do not cause disease in humans, it is not warranted, no? It is not warranted to give anti-amoebic drugs, or we do not medicate people. We do not give medicine or anti-amoebic drugs to humans. But as a physician, you have to weigh things. You have to weigh things. Although this commensal may not potentially cause disease in humans, however, they're considered competitors in the intestine. They compete with nutrition, of course. So, as physician, we might as well give anti-amoebic drugs to kill these commensal parasites in order to stop the competition process. And also later, when in cases where humans become immunocompromised, meaning your immune system will not go well anymore, they might potentially become opportunistic parasite, which means that they do not cause disease for now, but once your immune system degrades or your immune defense falls down, they might attack your body if you don't do anything. So we might do as early as now, we might So as early as possible, we might give anti-amoebic drugs. Now, for epidemiological studies, it is important to speciate, no? It is important to speciate what amoeba are we dealing with. Are we dealing with pathogenic? Are we dealing with non-pathogenic? And if we're dealing with non-pathogenic, what type of amoeba or what specific species or genus and species are we considering? What's the value of doing epidemiological study? We look at the patterns or the life cycle of the parasite. We look at how the parasite spread. Because if we're going to study how the parasite lives, how the parasite survive, even if it doesn't hurt someone, it has a value to the environmental aspect. You know why? Because the mere presence of amoeba from your water or for the mere presence of amoeba contaminating water supply is an indication that your water supply are not safe at all. These are not clean to be with. And these are not safe to be taken by humans, diba? Or for consumptions. So that's the value of looking at the presence of commensal amoeba in the environment. You look at environmental sanitation. Although it may not necessarily cause disease to humans, but it is an indication that there is an environmental degradation, poor environmental sanitation. Okay? So to begin with, your commensal amoeba should be differentiated from Entamoeba histolytica. You don't because number one, we don't give excessive medications. We don't overtreat patients, no? For Entamoeba histolytica, if you listen carefully to my recorded lecture, you have to give adequate amount, adequate dosing, and frequency. So time frame has to be considered in order for us to successfully kill the parasite. For commensals, you don't necessarily give the optimum dosage. We do not give a specific timeline. We do not have a specific timeline. What we want to do is eliminate your commensal amoeba, not necessarily eradicating all life forms of your Entamoeba, like the cyst and histolytica. So what I'm telling here is, in a simpler term, what I'm telling you is when we see Entamoeba or when we deal with Entamoeba histolytica, we must give optimum and complete treatment to patients. But when we're dealing with commensal amoeba, it does not necessarily mean that we have to give the optimum treatment for the patient. Because in the first place, you may or you may not kill commensal amoeba. But for us clinician, we have to remove it because we have seen it already. And it might cause disease or harm to the patient when we don't do any action. Okay? So the three genera of intestinal amoeba that are considered commensal are your Indylimax, Ayudamoeba, and the amoeba. No? The third one would be the amoeba. Indylimax, your first is amoeba, no? In the previous lecture, we have differentiated non-pathogenic amoeba from pathogenic amoeba in terms of their structure, particularly the structures that is present in the trophozoite stage and the structures present in the cystic stage. What we know is that for the trophozoite stage of Entamoeba histolytica, they have one nucleus with a centrally located karyosome. And if you look at their cytoplasm, sometimes you will see RBCs, ingested RBCs, especially when you stain this the stool specimen. Huh? So what the medtechs do here for the non-medtechs is that they get specimen sample from the stool. The specimen requirement should be freshly evacuated stool, no? Freshly voided stool. So it must be transported to the laboratory in less than 30 minutes to maintain the viability of the parasite. Why? Because it would be better for us, for the medical technologists, to see the parasite moving, no? A moving parasite, a freshly voided stool, a freshly voided diarrheic or liquid stool would you would in a freshly voided diarrheic or liquid stool, you would appreciate the parasite better in terms of morphology and its movement characteristic, which is amoeboid in movement, amoeboid locomotion for the amoeba parasite, no? Especially for Entamoeba histolytica. Now, what other parameters that you can see, or what are the other pertinent things that you can see in the microscope once you examine a freshly voided stool under a microscope? So you get the stool sample and you put in a slide in the slide, and then you may also use or put iodine stain. The purpose of iodine stain is to delineate the structure of the cysts for the cystic stage. The value of putting iodine stain to to your stool specimen or fecal smear also is to look at the presence of red blood cell in the cytoplasm of the parasite. As I've told you before, the presence of the red blood cell in the cytoplasm is already indicative that this is a pathogenic amoeba. So this is a pathognomonic sign, in which when we say pathognomonic sign, this is only inherent to this type of parasite, to this species, and you may not be able to see this in other amoebas, especially for for the commensals. So you look at the cytoplasm, you look at the structure. You will find RBCs for Entamoeba histolytica tropozoite in the cytoplasm of Entamoeba histolytica tropozoite. But for the other amoeba, like your Entamoeba coli, which is the most common amoeba found in drinking water or in any water, the most common um, organism that you can find contaminating water. Even it is a common contaminant, it will not give you disease unless you have a very sensitive GI tract and you were raised by rich parents and you can't eat any food from the street, you might be sensitive to it. But because it is common, because it is a common amoeba, commensal amoeba, it might potentially infest or infect, or shall we say contaminate many bodies of water, and you might be interacting with the parasite in your daily lives, and it does not cause disease, no? So Entamoeba coli does not cause disease. Now you look at if you look at the smear, no? If you look at the specimen or the stool specimen from patients, they seldom complain of diarrhea, meaning rarely lang sila mag-diarrhea. They have rare diarrhea. If you happen to find Entamoeba coli in the stool specimen, it is just an accidental finding. When patient complains of diarrhea, most of the time in a clinical setting, it is not due to Entamoeba coli. It could be something else that is pathogenic. So the finding of E. coli in a stool of a patient with diarrhea or someone with GI problem could just be accidental, no? Maybe there's another underlying pathology or another underlying culprit with this. But then again, since your patient had Entamoeba coli based on the medtex report, you have to give patients medication. We can medicate the patient, okay? Now, looking at the structure of Entamoeba coli in comparison to your Entamoeba histolytica, they have small differences in terms of microscopic structures. They have an ectoplasm, a cytoplasm, but one thing you have to note in the cytoplasm of Entamoeba coli, they're more likely vacuolar. There are a lot of vesicles and vacuoles, no? This is owed to the ingestion of carbohydrates by the parasite or by the commensal. They do not ingest actively red blood cell, but they might ingest dead debris, dead bacteria, live bacteria. They might also ingest dead cells, but they don't really ingest active red blood cells. Actively ingest red blood cells. They might ingest dead ones because that's the purpose of your Entamoeba coli. They are scavengers. Scavengers. They don't actively parasitize. They don't cause damage, but they just scavenge, no? Scavengers. Now, for the cyst of your Entamoeba coli, they have also a distinct characteristic. Most of the time, the cyst will have more than 4 nucleus or nuclei. If it is less than 4, then it is not Entamoeba coli. Usually, if less than 4, Entamoeba histolytica for the nuclei. Now, the other two genera that I forgot to mention that are important to mention in your commensals with your commensals is your Indolimax. They have a they have a vesicular nucleus, a large irregular shaped karyosomes anchored to the nucleus by achromatic fibrils. Iodamoeba is characterized by a very large chromatin-rich karyosome surrounded by a layer of achromatic globules anchored to the nuclear membrane by achromatic fibrils. All of these species have cyst forms, no? So they have tropocyte and the cyst form. So the method of transmission from one host to another is ingestion of a cyst. Now there is an exception to the rules among commensal amoeba. Entamoeba gingivalis has no cyst. So the only way that you can get infected with this organism, with this parasite, is through ingestion of the tropocyte. However, the tropocyte stays in your mouth and it does not go to the GI tract. So they thrive in your tartar, they thrive in the sockets of your gingiva, and they even causes unsa man, bad breath or halitosis. So they are also scavengers in your mouth. So how do you get infected with this parasite? Through kissing or sharing of contaminated utensils. You can get sharing the saliva contaminated with Entamoeba gingivalis. So here, similar, most likely has a similar life cycle with your pathogenic amoeba or the Entamoeba histolytica. They mature your Entamoebas and the Limax and your Iodamoeba is taken up by eating contaminated food or drinking contaminated drinks. They excess in the small intestine. They resist the killing of the acid from the stomach, and then they survive in the small intestine and excess there. They become your tropozoites and they multiply by binary fission. And once they go to the large intestines, they form again cysts to continue the lineage by mixing with the stool, and then once the stool is evacuated, they may pass on to the next host. So in terms of pathogenicity, in the Entamoeba histolytica, remember, is the only pathogenic. Your Indolymax and Iodamoeba are non-invasive and are considered commensal, meaning they do not cause disease. Commensals. Okay. So here we compare the structure. So this is the laboratory, on the laboratory aspects. In terms of the structures, this is the differences of your, these are the different characteristics of your Indolymax, Iodamoeba, and your amoeba. They also have small differences in their cysts. No, so basically, or virtually, you may not be able to distinguish one from another basing on their morphologic characteristic alone. But if you are a keen observer, a keen parasitologist, you may be able to distinguish them. But in a clinical setting, once we see once we see reports, it is easy for us to medicate, right? Because we just let the patient void his stool and then submits that for stool examination and let the medic do the identification. Now, what's the value of identifying the parasite in terms of the clinical characteristic? The value of identifying the parasite, whether if it is a commensal parasite or a pathogenic parasite, is our method or approach in managing. What would be the appropriate management if we see this parasite? If the patient complains of this kind of sign, of this type of signs, or if the patient is complaining of the signs and symptoms of this condition, no, that's the value for clinicians. But for the value of looking into the educational part or the educational or information, no, looking into the information as to epidemiological differences or as to epidemiological survey, we look at the differences of the trophozoite and the cystic stage of these parasites. Here, morphology classification, laboratory, no? You have you may not be keen on differentiating um the morphologic characteristic of this different parasite in terms of their trophozoite stage and cystic stage. Again, that is expected. As physician, it is expected for us to recognize if there is parasitism. It would be of value to be able to determine if it is a non-commensal or a parasitic or a pathogenic amoebiasis because of epidemiological reason. Epidemiological reason na jud na if we want to determine and speciate these parasites. But then again, we will take up the clinician's hat, and then the clinician hat will tell us, are we going to treat this patient? Yes or no? If it is a commensal parasite, are we going to treat it? If it is a pathogenic parasite, if it is a pathogenic amoeba, if you're going to treat it, what is your treatment of choice? How long are you going to manage the patient? How long are you going to give medicine to the patient? And what is the appropriate dose? Because if you're underdose, if you're not giving adequate dose, an optimum dose to patient, the parasite might revive or might come back again and cause resistance to the amoebic drugs. That's what we are scared about, resistance there will be a point that the parasite will not be killed by your routine amoebic drugs, anti-amoebic drugs, because you did not actually or adequately kill the parasite because of unoptimum doses or suboptimum doses. Now, Intamoeba dispar, no, morphologically similar to Intamoeba. It is not pathogenic. Remember this. When we say they are morphologically similar, the only way that you can distinguish dispar from histolytica is through DNA and ribosomal analysis. DNA ribosomal or RNA sequencing or RNA synthesis. And we also have Intamoeba moscovi, no? Common in North, ano to? Common, unsa to ma'am? Common in North America, Italy, South Africa, Bangladesh. So your Intamoeba moscovi is also a non-pathogenic parasite. So you may not be able to morphologically distinguish just with Intamoeba histolytica, but it is important for you to look at the signs and symptoms and the disease characteristic brought about by the parasite, because your Muscovy, even though you can isolate this, or it may be isolated in these different countries, you still have to consider the signs and symptoms of amoebiasis. Thank you, ma'am. Now, what particular characteristic that is inherent with your Muscovy is that its ability to survive even at suboptimum temperature. The very cold temperature or ano yun? Ice kaning mo ice na 0 degree, and even at the not the boiling point, 41 degrees high temperature. Even if in high temperature or a very low temperature, it can survive. Unlike your Intamoeba histolytica, wherein it can survive only at body temperature or room temperature. Intamoeba hartmanni, oh, another relatively similar in terms of characteristic morphology to your Intamoeba histolytica, but it is a bit smaller compared to Intamoeba histolytica. Indolaimax nana, similar in frequency with Intamoeba coli, which means that this is common, just like your Intamoeba coli, which is a common contaminant, but they do not cause disease. Now, they have a blunt hyaline pseudopodia and for locomotion in a large nucleus with irregular karyosome. And what you will see in the cytoplasm are large vacuoles that contains ingested bacteria and even carbohydrates. They are quadrinucleated parasite when they become mature. So 4 nucleus or 4 nuclei. Eudamiba bushli. Of all the Intamoeba, this is the most distinguishable. You know what? Because of the large glycogen vacuole present in the cytoplasm. The large glycogen vacuole itself is already a distinguishing characteristic of Eudamiba bushli. That's why all fecal specimens, all fecal smear, when we examine specimen from stools or evacuated stool, we have to have a smear with plain or with a normal saline solution to act as a kanang a suspensory liquid. And the other smear, we stain it with iodine dye because we want to appreciate and look at the vacuoles present. If you see a large glycogen vacuole, It is somewhat characteristic of Amoeba bushli or bushli. And of course, Entamoeba coli. I keep on talking about Entamoeba coli. It's just like Entamoeba histolytica, but not pathogenic. It is also large. It can even grow larger than your Entamoeba histolytica because it eats most of the time. It is considered a scavenger. Its pseudopods is broader and blunter, and it's moves slowly compared to Entamoeba histolytica. It has a thicker, irregular peripheral chromatin with a large eccentrically located caryosome, meaning off-centered. Dili siya centrally located compared to Entamoeba histolytica, which is centrally located. And the morphology, larger, maybe larger because it keeps on eating compared to Entamoeba histolytica. It is not invasive, therefore it is just a scavenger. It keeps on eating and eating on the surface or lining on the top on the surface of the epithelium. And most of the time, it doesn't have an ectoplasm because its cytoplasm is filled with a lot of food debris. And what you have to remember is that um, the chrom the chromatoid bodies, no, is a lot slender, thinner compared to the thicker chromatid bodies in the cytoplasm of Entamoeba histolytica. So the chromatid bodies is slender and thinner. What you need to look at for the cyst is that it has more nuclei with more than 4 nuclei compared to the Entamoeba histolytica, which has 4 or less. And we have the Entamoeba chattoni and poliki. Diba? Your Entamoeba histolytica occurs in human to human. If you got the parasite from the pigs and monkey, then for sure that is not Entamoeba histolytica. It could be chattoni or poliki. Poliki. Although there are some instances where it can spread from human to human, but you can get infected from pigs, or you can infect pigs from humans. And I mentioned earlier gingivalis, Entamoeba gingivalis. This is the only known amoeba without the cyst stage. So transmission is ingestion or transfer of trophozoite from saliva contaminated with the thrombozoite. Contaminated saliva. So they eat the debris and food from the mouth of the patient. So that's the first part. Those are the entamoeba, the non-pathogenic or the commensal amoeba. Let's go to the second one. Let's go to Naegleria, no, or the acanthamoeba, the free-living amoeba. Free-living amoeba, when they say free-living, they're ubiquitous in nature. Ubiquitous in nature, you can find them especially in water bodies and or bodies of water and water stream. They can potentially cause disease, deadly disease in humans once they infect human. Free living amoeba, they keep on swimming in the water, but once they infect human, they cause deadly diseases. And what are these diseases? So your free living amoeba are of two genus or two species. We have the Naegleria and the species in this genera or genus is Naegleria fowleri. The other one is Acanthamoeba. We have not yet identified a species in the Acanthamoeba genus Acanthamoeba. So your the genus Acanthamoeba has two forms, the cystic or the cyst and the tropozoid forms. So cyst happens when the environment does not favor the host it does not favor the parasite. They try to insist. They form cyst. Whether cyst and tropozoid, what is inherent in your acanthamoeba is that whether cyst or tropozoid, they can infect humans. For the Naegleria, they have no cystic stage seen. So the tropozoid is the one infecting humans or host. Yeah, brain eating. But to be more specific, they can cause encephalitis. Not necessarily brain eating, but they cause encephalitis or inflammation of the brain parenchyma. Now, for your Naegleria, they have a smooth edge because of the lobate pseudopods. For the acanthamoeba, from the word acanthocyte, meaning thorns, no? Thorns. So they have thornly structures, and these are their acanthopods, no? Acanthopods, acanthophobia, which are filiform pseudopods. So this is the appearance of an acanthamoeba possessed with acanthopods or acanthophobia. These are the thorn-like locomotor apparatus of the parasite, which may be distinguishable with Naegleria because they don't have a thorn-like structure or apparatus for locomotion. Instead, they have a lobate pseudopods. So for acanthopods, they have a thorn-like acanthophobia for locomotion. So your Naegleria fowleri causes your primary amoebic meningoencephalitis, as you have read in your chat group. Someone said brain eating parasite. Okay, because they eat up your neurons, they take up the tissues in your brain as their source of food. Okay, but they cause inflammatory process in your brain, which causes inflammation of the brain parenchyma, or what we call encephalitis. So they cause infection in the brain and your meninges. And most of the time, once they infect you, they have a short incubation period. They rapidly migrate to the brainstem and infect the brain and the meninges. And by the time the doctor considered this as primary amoebic meningoencephalitis, you're already dead. So diagnosis is of clinical value. You have to ask, you have to consider patient's signs and symptoms. Most of the time, when patient has encephalitis, they would complain of headache, change in sensorium, and sometimes fever. Paspas kayo. And if you're going to ask their history of travel or history, they just swam in a lake a few days ago. We had an incident in Luzon, no? There was an outbreak of Naegleria in Luzon years years ago when a adolescent swam in the lake and he suddenly develops signs of meningitis and signs of meningoencephalitis, headache, imagine headache, severe headache, chapaman, fever, change in sensorium, meaning disorientation, they're disoriented, they're not conscious, there's a change in sensorium, and the patient swam in a lake, it necessarily needs to be diagnosed rapidly. The only way that we can get a specimen is to do unsa man, autopsy to confirm the diagnosis. Although CT scan, MRI has of little value, but it can give you a presumptive diagnosis because CT scan and MRI will tell you that the patient have meningoencephalitis or encephalitis, inflammation of the brain parenchyma, but it will not specifically give you that the patient has primary amoebic meningoencephalitis caused by Naegleria. Initial symptoms, as reported, is that patients would have a runny nose, sore throat, severe headache. You know how? Why? Because once when the parasite is contaminating the water, people tends to swallow the water that he or they are swimming with. Swallow, matulon og tubig. And it so happened to be in waters like lake, dili nimo occur sa seawater, fresh water. Seawater will kill the flowelary. It cannot survive in seawater. So in fresh water like lakes, rivers, patient tends to swallow the organism. Patient tends to inhale the organism through the nose, and that's how they gain entry to the olfactory tract of the patient. And they travel from the olfactory tract to the brain via the olfactory nerve. So you have to look at the history again to diagnose. Patient was really healthy, and then a few days ago he was swimming in a freshwater lake, and then patient suddenly developed encephalitis. That's a high index of suspicion that this is primary amoebic meningoencephalitis. And when the patient succumb, mo progress, no, to severe forms of meningoencephalitis like lethargy, coma, it is usually followed by death. Wala ka nang magagawa once the patient goes into coma. So, if you ever catch, nga nakakamaayo sa parasitology, a patient with an initial signs and symptoms of meningoencephalitis, and if you have extracted the history very well, and the patient was well known to be healthy, so you have a high index of suspicion. You look at the epidemiology again. Where does your Naegleria thrive? Is it common in your place? Is it common in the lakes of Luzon or in the lakes of Mindanao? Because if it is common, then you might suspect that this is Naegleria infection or primary amoebic meningoencephalitis. You can start off with amphotericin B as the drug of choice. In the Philippines, because of poor education, patients do not go right away to the doctor. By the time they recognize that this is going severe and this is going alarm, this has become alarming, by the time they reach the hospital, patient is already in coma or severe or having severe meningoencephalitis. So treating them would not be useful at all. But again, we still give them amphotericin B. But most of the time, because they come in late, they will actually die. Now, your granulomatous amoebic encephalitis granuloma formation. When you examine the post-mortem or when you examine the autopsy when you examine the dead body of this patient, the brain, particularly the brain, the brain is characterized by granuloma formation, which means that granuloma is a slow, progressive tissue morphologic change. In your histology, you have I think you have you have tackled on granulomas, or if not, it in histology and pathology. Granuloma is a slow process of tissue changes from a normal tissue replaced by granulomatous tissue. So it's a slow process. So this type of infection takes time to develop. That's why it's called granulomatous amoebic encephalitis caused by Acanthamoeba. No? To name the species, Acanthamoeba castellani, no? Italian. So as described here, granulomatous man siya, always remember that it is a slow process. Granulomatous. It takes the progression of the infection slowly. That is why it is a more slowly progressive chronic form of disease, again associated with swimming. So in terms of mortality rate, Naegleria kills faster than your Acanthamoeba. Again, what is the history? Patient swimming, and then patient initially complains of a subcutaneous nodule in the nose. Then patient had nasal congestion, and then patient develops signs of meningoencephalitis like headache. And this organism has the ability to disseminate in the skin, sinuses, lungs, and the cerebrospinal fluid compared to your Naegleria, which does not disseminate. So only Acanthamoeba disseminates in other parts and other body parts. It can cause abscess formation, like what I said, granuloma. So pwede kang mag-abscess. Abscess is the formation of um, pus, nana in tissues. And your Naegleria, I mean your Acanthamoeba is also associated with keratitis. It can infect the iris, your eyes, and cause keratitis, eye redness, and eventually causes ulceration and ring infiltrations of the cornea. This is due to eye trauma, exposure to contaminated water. Once you're swimming in contaminated water. And there was also an incident of contaminated contact lens. Diba? Where do you put your contact lens? Diba? In the diluent, right? That diluent can be potentially be contaminated with your acanthamoeba. It can cause keratitis due to contaminated contact lens. So how do we diagnose? If the patient complaints of eye irritation, eye redness after swimming a few days before, or having contact lenses, wearing contact lenses, it's again a high index of suspicion. So you can be able to diagnose patients having a Acanthamoeba infection by examining corneal scraping and examine it under the microscope through histopathologic studies, and you will see trophozoites. So if the patient is diagnosed with acanthamoebic keratitis, our treatment modality is neomycin, polymyxin, gramicidin, propamidin, and miconazole. Combination of anti-amoebic and unsa man, antifungal drugs. If you do not treat the patient, they can penetrate and gain access to the brain. So have to treat the patient with this triple anti-amoebic therapy so that the parasite may be stopped from penetrating and escaping towards the brain. That's the end of their lecture. So thank you very much. So you study for the exam next week. It will include commensal, free living amoeba, and your what you call this? Your pathogenic amoeba. Now remember, guys, for your laboratory, our plenary session, so Dr. Murata will be grouping you. So you have ample time to prepare for the plenary session. So our plenary session will be on one. So March, no? March 1. March 1, guys.
Sir, yes, sir.
Plenary will be on March 1. Then for this week, you're done with microscope. You answer amoeba, huh? Amoeba and flagellates exercises. Okay?
Sir, yes, sir.
Nakagets ratanan?
Yes,
For
Doc.
your exercises, it's amoeba and flagellates. Okay, thank you very much.
Thank you, Doc.
Thank you, Doc.
Thank you, Doc.
Thank you, Doc.
Thank you, Doc. Thank you, Doc.
Alright.